All right, let's hit it. So I'm going to show you the approaches. We're going to do the Arcadia balloon from Merit, and we're going to do IZI, their balloon and cement offerings. And so let's start off with the transpedicular approach. Andy, give me an AP shot right there. So centimeter up, 2 centimeters out from the 9 o'clock and 3 o'clock portions of the pedicle. And so we'll come down, picture. We'll come down just to the upper outer portion of that pedicle, picture. Picture again. Picture again. And we'll start right there. Shoot that, please. Get a little, all right, picture again. All right. So as we enter the vertebral body, make sure and just stabilize the needle. The only thing critical here is that we do not transgress and go beyond the medial wall of the pedicle until the posterior portion is in the, well, the anterior portion is in the posterior portion of the vertebral body. So we're right at the margin, the medial margin of the pedicle. So now we'll take a look lateral, and we're going to look to make sure that our distal tip of the needle is just past the line of the posterior wall. And that's the only, you don't put the needle into the, go all the way lateral. So we don't go into the foramina, so we know in a superior inferior dimension we're okay. And on the lateral dimension, we're trying to miss the contents of the spinal canal. So if we're way past, way good. And to medialize this, we can even move this back posteriorly, picture, to the posterior portion of the vertebral body, picture that. And we can focus to medialize this. And this is with the bevel needle. And we can get way over into a good optimal position. Picture that and come back around. So if we want to stay in half of the vertebral body, we can go in the initial trajectory, as you can see from the needle outside the specimen here, that this is about a 45 degrees. So we're headed toward the middle of the vertebral. This is 45 degrees from the floor to the wall. Picture. So we're right smack in the middle of the vertebral body. So that's just transpedicular approach and a tip or trick to optimize your needle placement once you get into the posterior portion of the vertebral body. For parapedicular approach, we're going to go from a line from contralateral inferior to ipsilateral superior vertebral body. Picture. Picture. So on this line, picture here, we're one vertebral body width out from the upper outer portion of that corner. And that start point where I have my 11 blade right there is the start point for a parapedicular approach. You notice it's just the same as a transpedicular approach, it's just farther out. So we'll start right here, we'll come down over the top of the TP. At this point, we're gonna rotate about 10 degrees ipsilateral toward me. And we'll take a picture there. And we're headed directly toward the vertebral body. And when we contact os, we're just in front of the pedicle. We're outside, but in front of the pedicle, just above the equator, the mid portion of that pedicle. So that's an ideal start point for a parapedicular approach. Now we're going to come back just directly AP, just like we had it. And we're going to use the same principles here. We don't want the needle to transgress the medial wall of the pedicle before that tip is in the posterior portion of the vertebral body. And so let's take a lateral view there and check our depth. And we know that because of the bevel needle, if we come up, I kind of hope we're not quite into the vertebral body because we can pull back and create a little bit more space by turning the tip contralateral. Well, we are, and so this is directed right toward the center of the vertebral body. We're just going to go ahead and place this into the center of the vertebral body, and it's very directable because you're not rocker arming this thing through a pedicle, the centimeter to a centimeter and a half tube of bone that is the pedicle. This is going on the convex portion of the vertebral body. The vertebral body, the somatic junction, right? As it goes, the body connects with the pedicle. We don't go through the pedicle, we go through the body somatic junction. So you're not having to, don't worry about rocker arming the pedicle off and fracturing it. Picture. So right smack in the middle of the vertebral body. The trick I was hoping to show you, picture this, is if you're right at the wall of the pedicle and you're worried and you're not quite past the posterior portion of the vertebral body, the needle bevel is facing inwards, and I'm just going to do a 180-degree turn on this, and we're going to picture it again. It creates just a couple of millimeters more space to steepen the needle and get past that posterior wall. Okay, finally, the extrapedicular approach, we're going to go 45 degrees off midline, and we're going to start just above the inferior end plate and the anterior portion of the vertebral body, just between the mid portion of the vertebral body and the inferior end plate. And this is at 45 degrees. And the only thing here that's a little bit tricky is sometimes you need to have something to secure the needle because it's outside the multifidus. It can be a little bit floppy. And I'm going to get a driver, and we'll stabilize this a little bit. Try to picture that. So, picture that. So that's a pretty good target right there. Shoot that. Picture. So that's a good spot right there. And I go down until I feel os. I'm going to tap it in. The only issue that is tactile that's different than the transpedicular parapedicular approach is sometimes it's hard to feel the cortex. It's so thin. Picture that. So I'm going to put the driver back on. This part's a little bit harder, which is not how it is in people that are unfrozen. Picture. Yeah. Move it back a little bit. And so we are between the mid portion of the vertebral body that has the radicular artery and the inferior end plate. So we're going to enter at that point. The red flags here, if we go back more posteriorly, we're going to hit the nerves, descending rami. If right around the mid part of the vertebral body is the radicular artery, and just anterior that are big red and big blue, but there's a whole big swath of territory, essentially anterior to the pedicle, inferior to the radicular artery. That whole area all the way out to the anterior portion of the vertebral body is relatively avascular and aneural. So we're going to come back in an AP view, and we're going to advance the needle into the vertebral body. Fantastic. Good. Picture that. Okay, let's put it kind of in the middle. Picture. All right, let's go lateral. And it's a different type of look, it's a different type of approach. The full name of this approach is called the Modified Inferior End Plate Extrapedicular Approach. This allows you to get in the mid-anterior portion of the vertebral body, and as I mentioned, there's a wide swath of territory that's relatively avascular and aneural. And so this is an easy way to get around hardware, to get into very collapsed vertebral bodies that are vertebral plana. You can put large volume devices in there. Like the old stacks that is not around anymore, or anything that's ridiculously large like that. That's the modified inferior end plate extrapedicular or the extrapedicular approach. So let's go do the regular transpedicular approach and do a balloon kyphoplasty. So we're going to use the Arcadia balloon. We're going to start with the needle, then we're going to go to the power curve. Picture. Shoot that. Okay, let's go lateral. And the power curve is the device, let's go lateral, yeah, that curves toward the arrow, this arrow, And as you make clockwise turns, this will turn toward the arrow, and it's beveled so it goes coincident with the bevel. It exaggerates the natural steering capability of this, and this will go all the way to 90 degrees. So this is very nice steerable needle. So we'll start right about there. That's a good starting position. And we'll put the power curve in, and we'll curve it toward the center. We're demonstrating the Arcadia balloon picture. And the Arcadia balloon is a balloon that is unilateral, that's designed to go picture into the anterior third to a half of the vertebral body. And this is designed to reduce the front part of the vertebral body, picture. Good. Can you drop it down a little bit, Anthony, right there? Picture. Okay. Picture that. So starting to come back toward us. Let's take a shot, AP shot, see how medial-lateral we are. Keep that lateral shot in our mind's eye. Good. And I'm going to drive this a little bit farther toward the contralateral picture. Picture. Let's take a lateral.
Target is medial border of the contralateral capsule. Medial border of the contralateral.
And once we get in the final position, then we'll take this out and we'll put the Arcadia balloon that has, it's the same degree of angulation. Picture. Picture.
It's coming directly at us. That's why you see it as a circle. It's coming on
As the power curve. Picture. Okay, good. It's starting to curl back toward us. Let's take an AP shot. We'll grab the balloon. And the balloon is, this is a large balloon, it's 25 millimeters. And it has the directional capability with, again, the clockwise turn that turns the balloon and shapes it to a curve identical to the Arcadia, or the power curve balloon. This is the Arcadia balloon picture. Good, good position. So we'll take power curve out. We do this by counterclockwise turn, gentle and steady traction. Okay. And the Arcadia balloon has a proximal portion on it. This is the this has the ability to collapse the balloon and reuse it. This is the only balloon that I know of that's designed to be used at multiple levels. Okay, picture that. Okay. We'll see if we can get it to parallel the pathway. If we can't, I'm going to reinsert the power curve. Shoot that. Picture. Okay. We'll try that one more time.
Puts the balloon in the most significantly powerful supportive
Picture.
body. The implant will have the maximum.
So we'll take a little bit of rightward turn just to make that picture, just to advance that, be able to advance the whole thing.
Front of the balloon is at that knob.
Picture. Very nice. Across midline, I'll pull the balloon, the cannula back a little bit. Picture, and let's take a lateral shot now. This is a fairly large balloon with a large volume. So we'll see what we look like on the lateral, and then very likely go ahead and inflate. Good. Picture. All right. Picture. 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 It's going to reduce the superior end plate deformity there. Picture. Very nice. Picture. Okay. And
Could you show that on AP?
yes, let's come back around AP. You can see it has, this cadaver has a little bit of osteopenia or osteoporosis. You can feel that the bones are relatively soft, and you can see the reduction of that. So very nice. And we'll deflate and then fill with cement.
Draw a straight line down, pedicle above, pedicle below. You want to get that balloon to span across the center of the vertebral body.
All right. Okay.
You saw how he struggled.
All right, so this goes all the way down. The cement filler will attach
Because when the balloon inflates,
to the cannula approximately.
when it collapses, it doesn't collapse.
Picture. Okay, let's go lateral, and we will fill
Opening of the cannula.
using water pressure and the cement, the stability cement. This has an incredible working time. This set time on this is 35 minutes. So just a remarkably long working time. So we'll just inject anteriorly, and we'll see that it's going to fill anterior, and then we'll go into the cavity creation that is the balloon, the void that the balloon left.
Hey, Doug, can you hear me?
Yes.
Can you talk about cement leak into discs, how much you worry about that as compared to total volume going into the bone?
Sure. Cement leak into disc has two real things that are associated with it. One is premature disc degeneration. That doesn't really apply too much because most of the people that we're going to be doing this on, the average person is a 75-year-old thin Caucasian female of Northern European descent between 3 and 8 comorbidities. You're not really worrying about premature disc degeneration in her. And also a predisposition for additional fractures, additional or adjacent level fractures, mainly adjacent level fractures, because the more cement you get into the disc, the greater the amount of risk that there is for adjacent level fracture. And the more anteriorly it gets in the disc, so the greater the amount, and the more anterior there is, the greater the risk of adjacent fracture. But one of the things I see that's probably a much more common error is people get a little extravasation into the disc and they start to freak out, and then they shut down and don't accomplish the goal of stabilizing the vertebral body. So I'd much rather have leakage into the disc, much rather have leakage into the disc with a stable fracture than a little bit of leakage into the disc and not having a fracture that's stable enough. So just remember to finish the goal.
How much would be too much into a disc?
There's no amount. I mean, so I fill the disc purposely sometimes. If I have two fractures, let's say an L1 and an L2, and just a completely capacious disc that's filled with air, sometimes I'll cement the disc as well, as you don't want to have, two augmented vertebral bodies with, a disc that's unstable. Let's take an AP shot. So, I mean, it doesn't really matter. And I don't want people to focus too much on intradiscal extravasation because it causes people not to do the goal, which is to make a solid intrabody strut that transmits force. I got a little leak outside. That's all right. Looks pretty good. And that leak outside is from, does anybody know what that's from? Why we got a little leak outside? That's leaking out our parapedicular hole. So there we go. That is a transpedicular kyphoplasty with the Arcadia balloon and the power curve. Okay, so let's transition. We're going to do another one. We're going to use the IZI system that has Vertifix HV. We're going to use bone fillers too, and a little bit different system. This is a very similar type of needle. It's a 10-gauged single bevel needle. And let's try the one directly, the vertebral body directly below it. Picture. Let's go down a little bit. Okay. Picture. Try with our start point. Picture. 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 Let's try it about like that.
On this side,
Good.
down here.
Picture that. All right. As we come down, I'm going to try to tag the middle of this. Let's go lateral, please. We'll use a single balloon for this, and so we'll try to get toward the middle. I started in a parapedicular manner outside, so we should be able to go ahead and angle this over to the center of the vertebral body. So picture that. So I'll pull it back a little bit, and we'll aim toward the center of the vertebral body. Picture.
Bevel toward the center.
Picture.
Here.
And we could, at this point, drill a little bit, but I'm going to speed this demo up back around AP. So we're in the middle anterior portion of the vertebral body. We'll come back around AP and see probably that we're in the center of the vertebral body. Proportionally, probably the same position because we're at about 45 degrees. And so proportionally the same position. We're in the center anterior, we're kind of in the center contralateral portion. And at this point right here, I'm just going to put the balloon in, then pull the cannula back. It kind of saves time and obviates the need to drill. So we put the balloon in, and I'll put this in picture. I may put that out just a little bit farther. Sometimes the balloon will go into the medullary bone and advance without much effort, but this one's not doing that, so I'm going to take it out just a little bit farther. Picture. And we'll take the stylet out, balloon in, pull the cannula back, picture, and there's our balloon. We'll get an inflation here.
From the medial border of the pedicle on the opposite side.
Picture.
The ribs will have a-
Come on.
and the support.
All right, let's go lateral. So this has a clutch on it. It's rated to 440 PSI. And what you're seeing is this clutch being overridden. That's the clicking noise. And this vertebral body has some hard spots in it, so we may not be able to get that balloon all the way inflated. That's about as good as we can do right there. So I will deflate, do it by just pushing the lever and pulling back, and this will deflate the balloon, picture that, and we'll remove it. And we'll fill this up with what's called Vertifix HV. These are bone fillers, and this is designed to have really good tactile sensation because this is metal and metal. And we'll put this through the needle into the vertebral body, picture. Picture that. Picture. Okay. And then we'll inject the Vertifix right there. And this has about a 20-minute working time, even a little bit more than that. I've used this cement all the way out to 24 minutes. So both of these cements have an exceedingly long working time. This is a lot longer than typical. And what you'll notice about this cement called the Vertifix HV is that it has little speckles in it, little dots. And those dots are barium beads. And this is designed to see flow. And typically when you're injecting it through a cannula, you can't really tell how fast the cement is flowing or is it building up pressure. This is designed so you can actually see the flow. And one of the other things too, it's designed to see where the cement is deposited. So cement is deposited a lot more densely in one spot than the other, typically at the area where the cement is being injected into the vertebral body. But this is something I don't think I was aware of until this cement, until we have barium impregnated beads. The only cement like this was previously made by Care Fusion. So, and we can see this flow, and it's flowing into the center of the disc. Very nice fill, center of the vertebral body. Very nice flow. And our goal is between the pedicles, end plate to end plate. That should be everybody's goal. An intrabody strut. Picture. And the single modifiable thing that you can do for better and longer term pain relief is more cement. And so we're going to fill this sucker up. Okay. This mixes up about 18 cc's of total cement, which is a real pleasure for me because we tend to use lots of cement. And I think there's one mistake that is made for manufacturers. They don't give us enough cement. And let's just inject the rest of this stuff in. Thank you. Picture there, Anthony. Okay. Picture. Have to hold the whole thing in there. HV stands for high viscosity, and it is that. It's a little bit of medium high viscosity. The Pascal seconds on this, as mix and go, 350 Pascal seconds, mix directly out of the mixer and go. And then, of course, it gets more thick. The viscosity measurement goes up the longer the cement has a chance to cure, of course. Picture that. Picture. Okay. Picture. All right, very nice. I think we'll stop there. That's end plate to end plate, and we'll take an AP shot, see how that looks. And that is beautiful. Very nice. So that is the IZI system for vertebral augmentation kyphoplasty. Questions, comments?
Any questions from the audience? Yes, please.
Dr. Beall, could you go through what you're looking for in imaging to determine which access approach you're going to take?
So can you say the first part of that question again? It is hard to hear you.
What do you use for imaging parameters to identify which approach you will take?
Yeah. So let me give you some of the obvious first. If somebody has hardware, we use the extrapedicular approach. If I need to get reliably toward the center of the vertebral body, I use the parapedicular approach. Transpedicular approach used for certain things like spine jack and other devices are designed only to be placed through a transpedicular approach. I think the best thing to do is to have all three of these approaches in your armamentarium and then choose the best one based on the situation.
Based on, say, a percentage, what percentage of these approaches do you You're 30% which, 50% which? What's your go-to approach?
Parapedicular is our go-to. So our start point, the difference between centimeter up to centimeters out, transpedicular, and the parapedicular start point is exactly the same angle. It's just farther out. That's the only thing. It's just farther out. We come down at 30 degrees, and probably do 75% of mine to be parapedicular. The rest of them, 20% transpedicular and 5% extrapedicular.
Okay, great. Last question.
Can you comment a little bit on when you're treating severe thoracic fractures and how you think about your approach differently in thoracic versus lumbar?
Yeah, so thoracic, whether you realize it or not, will be parapedicular. You can aim transpedicular, but most of the thoracic pedicles of above about T9, maybe T8, will be so thin you're not really going transpedicular, even if you think you are. So if you look at something, you try to do para or transpedicular and you CT scan people afterwards, you'll find that you will go sometimes transpedicular, sometimes you go in the side of the pedicle, sometimes you go at the pedicle somatic junction, sometimes you go directly into the vertebral body, just anterior to the pedicle. So in the thoracic spine, most of these accesses will be parapedicular.
Thanks, Doug.
Thank you, guys.
So for surgeons, we use the terminology in, out, in the thoracic spine because of the narrowing nature of the pedicles. So you think you're in bone to begin with at the transverse process or costovertebral region. You actually go out of the pedicle laterally, and then you go back into the pedicle at the pedicle soma junction. So you're starting in bone, and then you're going outside of bone, then you're going back into bone to end up in the dead center of the vertebral body in the anterior third, which is where you want to park your needles, in the anterior third of the vertebral body from a bipedicular approach, but it's in, out, in.